Thank you very much for having invited me to this meeting. And I haven't... sorry. Yeah. This is the headline of my presentation, Diabetes mellitus and NAFLD, two sides of the same dysmetabolic coin. And this is my disclosure also, although I haven't any conflict of interest today. Over the last decade, dramatic changes toward moving toward a more sedentary lifestyle and high-fat and high-sour diet have radically affected the health metabolic status. Chronic metabolic diseases such as type 2 diabetes, obesity, or NAFLD have been increasing at an alarming rate globally in both developed and developing countries. The global prevalence of NAFLD among general population is estimated to be 24% at present, but among diabetes population is up to 3 times more frequent, and up to 70 to 80% of patients with diabetes suffer from NAFLD. The relationship between NAFLD and type 2 diabetes is bidirectional. On one hand, people with NAFLD is at higher risk of suffering incident type 2 diabetes, and the more severe the disease, the more likelihood of developing type 2 diabetes. And on the other hand, people with type 2 diabetes are at higher risk of suffering steatohepatitis and have a 2-fold to 4-fold higher risk of liver failure, cirrhosis, and hepatocarcinoma. Insulin resistance has been characterized as a crucial pathophysiological factor in this disease, although other pathways are involved, such as mitochondrial dysfunction, adipose tissue dysfunction, genetic factors, and nutritional factors as well. There is a complex multi-axis involved, and the traditional hypothesis where 2 main hits were involved, metabolic events and inflammatory events, have been proved that don't happen one after another but coexist simultaneously. Free fatty acids play a fundamental role in this disease, as they can be esterified with glycerol into triglycerides in the liver, can undergo beta oxidation, and can be exported from the liver in form of VLDL. These free fatty acids can also generate it from the adipose tissue, or can generate it from lipogenesis de novo from precursors such as glucose or fructose. This process is upregulated and supposed to be the hallmark of the disease. There is also an adipose tissue dysfunction with a decreased levels of adiponectin. This adipose tissue stores fat, and when its buffering capacity is exceeded, it is promoted the ectopic fat accumulation. And therefore, there is also a mitochondrial dysfunction with an enhanced ROS formation, and don't forget that there is also gut dysbiosis with an imbalance between bacteroidetes and firmicutes, predominating the last one that are more efficient at energy extraction. These all processes converge and culminates in a profoundly status of inflammation, and this is why there is this complex multi-axis where endocrinologists and hepatologists play a fundamental role together. We will go more deeply into the current perspective in management of type 2 diabetes, and just to begin, insulin resistance in the liver and the muscle and the beta cell dysfunction, beta cell failure, represent the core pathophysiological defects in type 2 diabetes, but other factors such as increased lipolysis, decreased incretin effect, increased glucagon secretion, and increased glucose reabsorption and brain dysfunction are involved. These 8 players comprise the amino octet, and we will require multiple drugs to correct all these pathophysiological defects. These are the family drugs of the anti-diabetic drugs that are available in the market to treat diabetes. On one hand, insulin sensitizers such as metformin or pioglitazone. On the other hand, insulin secretagogues, sulfonylureas, and meglitinates. Also, SGLT2 inhibitors that act via the kidney, and all the hardly used alpha-glucosidase inhibitors. When it's about the management of type 2 diabetes, there are so many guidelines. What everyone agrees is in the comprehensive management of type 2 diabetes, taking into account not only hyperglycemia, but also other comorbidities, hypertension, obesity, or NAFLD. These are the profile of antidiabetic medications, and some of the drugs that fulfill some of the advantageous conditions that we expect from oral antidiabetic drugs are SGLT2 inhibitors, GLP-1 receptor agonists, because of its neutral behaviors in terms of hypoglycemia, its benefits in terms of weight loss, renal and cardiac protection in light of cardiovascular safety trials. The first-line therapy is metformin, remains metformin, but if hemoglobin A1C is about target, we will have to focus our attention on the patient, and if it is established, if there is established cardiovascular disease or chronic kidney disease, or by the contrary, the patient is in a primary prevention scenario without established cardiovascular disease. And if whether there is a compelling need to minimize weight gain or avoid or promote weight loss, in which cases GLP-1 receptor agonists or SGLT2 inhibitors are the best choices. What antidiabetic drugs are the most appropriate for NASH and NAFLD? Well, the ideal treatment must have weight-reducing efficacy, reduce cardiovascular events, must have a preventive behavior in hepatocarcinoma, and improve quality of life. But disappointingly, there aren't any approved diabetic therapy yet to date, and only pioglitazone is mentioned by some guidelines and some papers. Metformin remains the first-line therapy by the guidelines, ADA and ESD, but have no data regarding its improvement in liver histology in NAFLD and NASH, although it reduces the incidence of hepatocarcinoma and other extrahepatic malignancies. What oral antidiabetic drugs are considered in NAFLD and NASH guidelines? Well, pioglitazone, it's mentioned and can be used in patients with biopsy-proven NASH, but we will have to discuss the benefit and risk with the patients because of its concerns related to weight gain, fluid retention, bone fracture, and bladder cancer. According to the American Association for the Study of the Liver Disease, it is insufficient to consider GLP-1 receptor agonists in the treatment of NAFLD and NASH without diabetes because of its insufficient evidence. What is the perspective from the endocrinologists according to the standard of medical care in diabetes recently? They recommend intervention that improve metabolic abnormalities, such as treating diabetes, hyperglycemia, weight loss, the reduction in consumption of alcohol. Also mentions pioglitazone and vitamin E in those patients with biopsy-proven NASH, although there isn't any longer-term beneficial outcomes yet. There are also other treatments such as liraglutide, dapagliflozin, and empagliflozin with some promising results in preliminary studies, maybe mediated by weight loss. The Spanish Society of Endocrinologists also mentions the potential benefit with EDP4 inhibitors and SGLT2, and state the benefit with liraglutide and pioglitazone, although there is no formal indication in its medication data sheet. Metformin is a big one that represents the first-line choice in therapy, but to date, 15 randomized controlled trials have been performed. In them, 7 of them biopsy were taken before and at the end of the treatment, and to assess a systematic comparison between a study, we count on 4 meta-analyses, where everyone agrees is the scanty role of metformin in over NASH, as no data regarding its improvement in liver histology has been shown, although improvement in body weight, in waist circumference, OMA index, and fasting plasma glucose has been shown. It could be useful in association with lifestyle intervention in the prevention of risk factor NAFLD, and have shown a protective role against all types of cancer. The molecular weight is still incompletely understood, but could be due to a decrease of RAS production regulating MPC. Another possible improvement in NAFLD and NASH is the interaction is attributed by interaction of metformin with gut microbiome. In fact, increases butyrate levels by colonic bacteria. An old friend for all of you probably familiar is pioglitazone, that is a piper gamma drug currently approved for the treatment of type 2 diabetes, as shifts fat from splanchnic and hepatic tissue to subcutaneous fat tissue and decreases in the levels of inflammation with a reduction in adipokines. This is an old friend, but we have to date, although around 15 randomized controlled trials, not only with diabetic population, but also with non-diabetic people, such as PIVEN trial, where only the resolution of NASH was improved and the primary endpoint wasn't achieved. Moving now to GLP-1. GLP-1 is an incretin hormone that is released by intestinal cells in response to meals that is responsible for stimulating insulin secretion, inhibiting glucagon, and maintaining, therefore, glucose homeostasis. But beyond these effects on glucose metabolism, there are other pleiotropic effects, such as delaying gastric emptying, decrease in appetite, cardiac protection in terms of contractility, natriuresis in the kidney, and beneficial in the liver, and it's beneficial in the liver. But the presence of GLP-1 receptor agonists in human hepatocytes is controversial, and the mechanism by which GLP-1 receptor agonists act on the liver remains to be established. In some animal preclinical models, have been shown that GLP-1 act decreasing levels decreasing the lipogenesis and promoting free fatty acid oxidation, and also attenuates pro-inflammatory responses. This is how GLP-1 confers a hepatocyte survivability and a protection in inflammation pathways. Some of these molecules are available in the market, such as semaglutide, recently approved, liraglutide, or dulaglutide. In the set of cardiovascular trials with these molecules, the net result is a cardiovascular benefit in terms of reduction of MACE point, considered to be a comprise of cardiovascular death, non-fatal myocardial infarction, or no-fatal stroke. But it is important to emphasize that this is achieved thanks to molecule derived directly from human native GLP-1, because the two molecules that are derived from exendin, that is Elixa and Excel, have failed to show these cardiovascular benefits. It's for clear that GLP-1 receptor agonists confer a cardiovascular safety, but what about the liver? What benefits have GLP-1 on the liver? This trial, the LEAN trial, that was a multi-center, double-blind, randomized placebo phase 2 study, randomized 52 patients with NASH, with biopsy-proven NASH, to receive lira 1.8 or placebo for 48 weeks. And as a result, the primary endpoint of the resolution of non-alcoholic steatohepatitis without worsening of fibrosis was achieved in 39% of patients with liraglutide versus 9% with placebo, and other improvements, such as improvement in steatosis and hepatocyte ballooning, were also achieved. But this study didn't give an answer about this, if this improvement were achievable thanks to a reduction in weight and hemoglobin A1C, or by the contrary, because of metabolic facts that were involved. To solve these doubts, a sub-study of the LEAN trial was assessed was conducted to assess this metabolic fact that could be implicated. And as a result, 14 patients, voluntary patients, were randomized to lira 1.8 versus placebo. Lira decreased BMI, decreased leptin levels, increased insulin sensitivity in the liver, suppressed hepatic glucose production, increased lipolysis, decreased lipogenesis, and independently of weight loss. And when the lean trial was published, only dose of 1.8 milligrams was approved, and subsequently the dose of 3 milligrams was approved in obesity. And this randomized control trial had as an objective to compare liraglutide 3 milligrams versus a structured lifestyle modification in 24 obese Asian obese patients. These are the results in this table. As we can see, liraglutide reduced total fat mass, reduced liver enzyme, but the effect was comparable with the lifestyle intervention group. Pharmacological therapy in weight loss is improving, and we can see in this double-blind placebo-controlled phase 2 trial with semaglutide, different doses of semaglutide conferred weight loss, not only compared with placebo, but also with doses of liraglutide of 3 milligrams, comparing to sema. The effect of semaglutide also was evaluated in this trial in relation to the liver enzymes in patients with elevated ALT in this phase 2 trial. And as we can see, semaglutide dose of 0.2 milligrams achieved a reduction in ALT that was, to an extent that was broadly comparable across the different weight loss categories, and supposed a normalization up to 46% with doses of 0.4 milligrams at 52 weeks, suggesting the possible role of semaglutide in treatment of NAFLD with elevated liver enzymes. Novo Nordisk is focusing now on the development of treatment for NASH, have 2 phase 2 trials with semaglutide and 1 phase 1 with a coagonist glucagon GLP-1. These are the design of the semaglutide NAFLD MRI trial and the semaglutide NASH trial. Moving now to coagonists, this phase 2 trial comparing a wide dose range of tirzepatide versus dulaglutide showed a significant and a meaningful superior hemoglobin A1C control and weight loss with both doses of tirzepatide versus dulaglutide, with an acceptable tolerability. In the battle of GLP-1 receptor agonists, the molecules are improving, improve longer half-life, and if we just had to put in a podium the different incretin hormones, we could say that semaglutide is a silver medal, but the golden medal is won by coagonist and triagonist. Just a brief video to show the benefits of the mechanism of action of sodium-glucose cotransport inhibitors in the kidney. Oh, sorry, the volume.
Regulatory systems have evolved to manage and retain glucose. But for modern humans, the availability of excess calories combined with a sedentary lifestyle may result in a surplus of energy. The sodium glucose transporter, SGLT2, is a transporter of sodium and glucose in the proximal renal tubule and is responsible for about 90% of the reabsorption of glucose in the kidney. By inhibiting SGLT2, renal glucose reabsorption can be reduced. This process induces excretion of glucose in the urine.
Yeah. After this brief video, I will show you that SGLT2 inhibitors are now widely approved antidiabetic therapy because of its unique metabolic glucosuria mechanism, also achieve weight loss, producing a negative caloric imbalance in the body, reducing total body fat mass and also visceral fat mass, reducing epicardial fat and ameliorating cardiac contractility. But perhaps more important are the osmotic and the natriuretic effects that confers a reduction in a plasma volume, which may underlie its beneficial in cardiac and renal terms. It also activates glomerular feedback, reducing hypertension, hyperfiltration, reducing albuminuria, and also exert a variety of additional metabolic effects such as the reduction in uric acid plasma levels. These all convey cardiac and renal protection, in light of robust studies of cardiovascular safety, such as EMPA-REG with empagliflozin and CANVAS with canagliflozin. This study show a reduction in MACE point that is a comprehensive endpoint of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, with a 40% reduction, and we will have to bear in mind that almost 100% of the population included in the study had arteriosclerotic cardiovascular disease. Also, it was shown that a reduction in cardiovascular death with empagliflozin and a reduction in hospitalization for heart failure in CANVAS and EMPA-REG studies. DECLARE-TIMI was also a multinational study conducted to assess the safety and efficacy of the dapagliflozin in patients with high risk of cardiovascular events, but only 40% had established cardiovascular disease. MACE points didn't appear to be superior, but cardiovascular disease and hospitalization for heart failure was reduced also in this trial. These drugs have a similar reduction in terms of body weight and hemoglobin A1C, and to sum up, whereas SGLT2 inhibitor reduced MACE in patients with type 2 diabetes with cardiovascular disease, prevention of heart failure was observed also in patients without cardiovascular disease. Summarizing all the previous information, all the previous slides, SGLT2 inhibitors have specific effects that are mediated by osmotic diuresis and natriuresis, a reduction in intraglomerular pressure and interstitial edema, and GLP-1 receptor agonists are more aimed at antioxidative and anti-inflammatory pathways, both share in common a reduction in plasma glucose levels, a reduction in body weight and blood pressure, and improvement in lipid profile, all improve of cardiorenal benefits, but with different performances. Whereas SGLT2 inhibitors have an early effect that are driven by hemodynamic effects, favorable in heart failure, GLP-1 receptor agonists have a late effect, more aimed at anti-thermomatous property and against ischemia. The effects of SGLT2 inhibitors on the liver have been proved mostly in experimental and preclinical models that suggest beneficial effects of NAFLD on NAFLD and NASH. The article published in Human are scarce, a majority published in Japan. Today, the effects of SGLT2 have been largely evaluated by biochemical markers and radiological quantification of fat, but the histological evaluation in humans are scarce. Only a few studies have been evaluated the role of SGLT2 inhibitors in liver inflammation and fibrosis, and most of the studies have a short follow-up with limited number of patients. As we can see, this meta-analysis, all these molecules, dapagliflozin, dapagliflozin, reduce body weight and improve liver enzyme, but in most of them, histology hasn't been assessed, only with epagliflozin that is not commercialized in Europe. Moving now to the possible mechanism of action of SGLT2 inhibitors on NAFLD, apart from the body weight reduction and reduction in visceral fat mass and also reduction in hemoglobin A1C, these drugs are confer benefits beyond these glycemic benefits that are, for example, reduction in inflammatory markers and oxidative stress. The hypothesis most accepted is the shift of fuel that stems from their glucosuric effect that confers a loss of energy, and this triggers the production of insulin, the production of glucagon instead of insulin. This promotes ketogenesis, lipolysis, and gluconeogenesis due to this glucagon effect. My last slide, a few words for insulin. That is a treatment of choice for type 2 diabetes in advanced liver disease, but it can be used in patients regardless severity of liver impairment. But don't forget that it's an anabolic hormone that increases body weight, and therefore we should delay its initiation in obese patients. And because of its concern about pro-oncogenic effect, it's not considered the ideal drug to treat type 2 diabetes in NAFLD, and we have to reserve it to patients with advanced cirrhosis or poorly controlled with oral anti-diabetic drugs. Just a summary of my previous slides, and this is a personal opinion. when facing a patient with type 2 diabetes and NAFLD or NASH, we will have to focus our attention in the lifestyle intervention, promoting weight loss. Don't forget bariatric surgery in those patients that are candidates, because it's the most consistent therapy for those obese patients. If the BMI is under 30 kilograms per meter square, we'll have to individualize treatment according to baseline hemoglobin A1C levels. If it is under SMILE control, between 7 and 8% of hemoglobin A1C, choose SGLT2 inhibitors, or if BMI is above this target or poorly controlled diabetes, choosing GLP-1 receptor agonist perhaps is more beneficial. And don't forget pioglitazone in those patients without risk of heart failure, bladder cancer, or bone fracture. And in patients with compensated cirrhosis, we can use whatever, but if patients have this compensated cirrhosis, we'll have no option, only treatment with insulin. And as a conclusion, NAFLD is one of the most frequent conditions in the world. Its rate is rapidly increasing. Type 2 diabetes is a risk factor of main order, with higher proportion of inflammation and hepatic damage. Many trials with anti-diabetic drugs have shown improvement in body weight and liver enzymes, but data regarding histology are lacking. Anti-diabetic drugs are promising drugs. All anti-diabetic drugs can be used with compensated cirrhosis, but still we have no data about advanced cirrhosis. We should prioritize drugs who favor weight loss and with cardiovascular protection, and definitely we need anti-diabetic trials with liver endpoints. And this is my team. I am very proud of them. I work in Hospital Macarena and doing mainly trials related to diabetes and obesity. And thank you very much for your attention.
Thank you.